The study showed an increased abundance of the lipophilic fungus Malasthesia restricta on the scalp of androgenetic alopecia patients. This fungus, Malasthesia restricta, is known to consume sebum, specifically consuming the palmitic acid, which could influence the health of the scalp and potentially exacerbate androgenetic alopecia. If your PPAR gamma receptor isn't working properly and you can't break down these lipids, it could lead to potential cicatricial or scarring alopecias on the autoimmune aspect. Because your body is freaking out and is trying to just stop whatever is producing those lipids by any means necessary, which would be targeting your sebaceous glands and destroying them. Hello everyone and welcome back to another video. Today we're going to be talking about some fascinating studies that particularly shine a light on the scalp microbiome and its relation to various conditions with a primary focus on androgenetic alopecia. Now, the microbiome, whether it's in our skin or in our gut, often doesn't get the spotlight it deserves in research. And there's also an intriguing concept out there that the gut and the skin have some kind of relation. They call it the gut-skin microbiome axis, or people use different terms sometimes, but it's generally that term. And this suggests that the state of your gut could potentially influence your skin health. And this idea is supported by researcher Apostolos Pappas' literature review titled, quote, "The Relationship of Diet and Acne," unquote, which discusses how one's diet can potentially affect sebum production. And we also know that DHT has a profound impact on sebaceous gland activity, influencing the output in terms of volume of sebum, but also the sebum quality itself. And we can get an understanding of this if we look at pretty much any literature review, but the primary literature review I want to bring up here would be one titled, quote, "An Update on the Role of Sebaceous Gland in the Pathogenesis of Acne," unquote, by Evgenia Makron-Tanaki et al. But I want to make this clear. If you're dealing with androgenetic alopecia, don't fall into the trap of thinking that you can cure it or stop it by just changing your gut health microbiome or doing some sort of fancy diet. I've seen this suggestion floating around a lot, and it's a bit misleading. Probably just really misleading, to be honest. I'm not going to get into it in this video, but we have tons of studies that show how DHT, for people that have the genetics for androgenetic alopecia, destroys the hair follicle over time. You know, in vitro and in vivo, we have all these studies that prove this. So it's not your gut that's making your hair sensitive to DHT. And people that propose that and comment that on these videos that I've seen all over the internet and even on my videos, listen, if you comment that on this video, I'm just going to ignore it because it's just annoying and it's distracting from the overall discussion of this video. And that's not to say that your gut health doesn't have any sort of, influence on your skin. It could very well be the case that your diet, yes, your diet can influence secondary conditions, maybe a seborrheic dermatitis. Or maybe if you have some sort of weird issue with your PPAR gamma receptor, that's where you start falling into conditions like lichen planopilaris when you have, excessive lipid buildup in your skin or in your tissues and your body can't necessarily break down those lipids. You get lipotoxicity, which ultimately leads to your white blood cells causing issues, lymphocytic infiltrate destroying the follicle organ and also sub-organs like the sebaceous glands and such. Yeah, maybe diet can potentially influence that if you have a poor diet where you're just eating, tons of processed shit. And, to be honest, there's also a genetic predisposition because we know there are people out there like, that Nikocado avocado guy. He just eats whatever he wants, or he used to eat whatever he wanted to. But when he was eating everything he wanted to, he had a good head of hair, right? So you have people like that. I just want people to understand that when we talk about the whole gut health thing, don't take it out of proportion to, over-exaggerate its importance to the point where you're literally saying that if you fix gut health, it'll stop the specific condition, androgenetic alopecia. No, we want to focus on the secondary impacts of what poor diet could probably do and what poor sebum and lipid content can probably do to your skin and hair follicles. So with that sort of disclaimer out of the way, let's get on with this video. So the first study we're going to be looking at is titled, quote, "Scalp Microbiome and Sebum Composition in Japanese Male Individuals with and without androgenetic alopecia, unquote, by Suzuki et al., published to Microorganisms, a journal, in 2021. Now, the findings from this study revealed that individuals with androgenetic alopecia had higher levels of triglycerides and palmitic acid in their sebum compared to those without androgenetic alopecia. Palmitic acid, a common saturated fatty acid, is of particular interest due to its implications in the skin's lipid barrier and microbial environment. The study showed an increased abundance of the lipophilic fungus Malasthesia restricta on the scalp of androgenetic alopecia patients. This fungus, Malasthesia restricta, is known to consume sebum, specifically consuming the palmitic acid, which could influence the health of the scalp and potentially exacerbate androgenetic alopecia. Furthermore, the bacterial composition of the scalp also showed differences between groups, with an increased abundance of Cutibacterium and a decreased abundance of Corynebacterium. Now, both of these bacterium are gram-positive bacteria, and they are very commonly found on the skin. But the Cutibacterium is more commonly found in the sebaceous glands itself, while the Corynebacterium is typically distributed everywhere. And I just realized, Cutibacterium? Like, oh, you have cuties? Do you guys remember that growing up? Where somebody would say so-and-so has cuties or whatever? I don't know, I just thought that would be interesting to add, so, getting back to the video. But it might be the case that as the Cutibacterium increases because of this specific impact that, whatever androgenetic alopecia is doing, and we know what it's doing, it's DHT that's causing these sebaceous glands to kind of act weird, right? As the levels of palmitic acid and other triglycerides go up, it's going to create a condition where the bacterium that are in the sebaceous glands will fester and eat up, those nutrients first before it can ever reach any other part of the skin. So the bacterium that tends to be outside of the sebaceous glands, they're not getting any sort of that sebum themselves, so they begin to dwindle in numbers. And this could be bad because some of these bacterium have very essential roles. They actually do good things for your skin. So, for instance, if we look at the paper, just briefly, right? Briefly look at the paper titled, quote, The Skin Microbiota, Balancing Risk and Reward, unquote, by Loris Flowers and Elizabeth A. Grice. We can get an understanding that the Corynebacterium species can inhibit other bacteriums that tend to cause skin diseases, essentially by producing free fatty acids that disrupt those pathogens' growth. So the Corynebacterium species tends to have this sort of competitive interaction with other harmful bacteriums. So if you're having a decline, as we see in this particular paper, it tends to be that men with androgenetic alopecia have this sort of decline of the Corynebacterium, then they're going to be placed at a higher risk of having these sort of skin pathologies, right? And they can have acne, they can have seborrheic dermatitis, and you can have seborrheic dermatitis on your face and your scalp, by the way. They're going to be at a higher risk for those kinds of things. And that's all because of there being an alteration to the lipid content of the sebum. And that alteration tends to favor bacteriums in certain areas of the skin, and it harms others in other areas of the skin, which very much so destabilizes people. And I know there are many people in my audience that talk about how, they had issues with acne, they had folliculitis in their scalp, and then they also had androgenetic alopecia. Those are all correlated to some sense, right? So we have to figure out what's going on here. And I think the mediating factor between all of this would be the lipid content, what your lipids are becoming due to the influence of various factors, whether it's DHT and also, to an extent, diet. But still, I want to, look at the graphs of this study now, right? If you look at the men with androgenetic alopecia, yeah, they had a higher abundance of Cutibacteria, but also the Staphylococcus bacteria as well. And we already know this leads to staph infections of many kind, like folliculitis, abscesses and boils, cellulitis, all, these are common things. And I just want you guys to, again, think what the issue here is. It's lipids. Lipids are causing this sort of change. Let's keep looking at the graph, right? You also have the higher, presence of specific fungi, the Malasthesia restricta. You get seborrheic dermatitis from that particular species, right? Not, just that subspecies, but overall that species itself. But ideally, there's a balance between all of these things. You kind of want them to have some sort of weird competition between each other, where you don't want to completely favor one completely over the other, because that can also tip it towards pathology. But we can clearly see from this graph that, and the graphs from this study, that certain things are just in higher prevalence with men that have androgenetic alopecia, and that will lead them to have a certain kind of predisposition towards skin conditions. Now, before we move on to the next study, I just want to look at this heat map from this Japanese Sebum androgenetic alopecia study, right? Because I think this will be a good way to kind of see actually what's going on, right? To see which lipids are more prevalent overall. So we're just going to run down the whole list itself. So the heat map displays the correlation between various skin lipids in the presence of different microbial genera, or I guess species or whatever, in two groups, right? So you have those with androgenetic alopecia and those without androgenetic alopecia. Those are the two groups we're focusing on. And each row here represents a different microbial genus, such as the Corynebacterium, Staphylococcus, and Malasthesia, among others. Each column here represents a type of skin lipid, including free fatty acids, triglycerides, squalene, and cholesterol esters. So the colors in the heat map range from blue to red, and blue indicates a negative correlation between the lipids and the presence of the specific microbial category or life, right? So meaning lower levels of the lipid are associated with a higher presence of the genus. That would indicate, again, a negative correlation. The red color to us indicates a positive correlation where the higher levels of the lipid are associated with a higher presence of that particular species of microbial life or genus. So the intensity of the color, again, keep this in mind, would represent the strength of the correlation, with the darker shades indicating a stronger correlation, and obviously the lighter shades being the opposite, a weaker correlation. So just a quick observation, in this heat map on the screen, you can see that the lipids of concern, particularly in relation to androgenetic alopecia, include triglycerides, squalene, and cholesterol esters, which show a notable presence and correlation with specific microbial life. So hopefully you can see what we've been talking about just by looking at this heat map. And just for the hell of it, so we can, understand what's going on, let's just focus on the Cutibacterium, right, between the AGA group and the non-AGA group, right? If we look at the category concerning free fatty acids, what do we notice? In both the AGA group and the non-AGA group, that cell, right, is dark blue. So what does that indicate for us? It shows us that regardless whether you have androgenetic alopecia or you don't have androgenetic alopecia, Cutibacterium is associated with the reduced levels of free fatty acids in the scalp or, scalp skin or whatever, right? However, when we look at the triglycerides in relation to Cutibacterium between the AGA group and the non-AGA group, we notice something, right? There is a light red color for triglycerides in the non-AGA group in respects to Cutibacterium. In the AGA group, we have a darker red color for triglycerides, suggesting a stronger association with higher levels of triglycerides. So this implies that in the AGA or the androgenetic alopecia group, that's what AGA means, by the way, androgenetic alopecia people, patients, whatever you want to call these, us, because if you're watching this video, you probably have androgenetic alopecia yourself, we tend to produce more triglycerides in our sebum. And those triglycerides feed the Cutibacterium, right? The same thing happens in people that have, non-androgenetic alopecia, people who don't have AGA, right? That same thing can happen in them. If you were to, give them a diet that increases their triglyceride output in their sebum, it could be the case that they would end up with having more Cutibacterium. Maybe it won't be as much as us, right? Comparatively speaking, because they have a whole host of, different bacterium that's also being fed other sort of lipids as well that can probably outcompete the Cutibacterium proliferation. But it just goes to show us that high triglyceride levels influence more Cutibacterium, which Cutibacterium tends to be associated with more issues, right? So hopefully that made sense and you guys can see how intricate and important sebum is in androgenetic alopecia. It could lead to other issues, seborrheic dermatitis, eczema, psoriasis. If your PPAR gamma receptor isn't working properly and you can't break down these lipids, it could lead to potential cicatricial or scarring alopecias on the autoimmune aspect. Because your body is freaking out and is trying to just stop whatever is producing those lipids by any means necessary, which would be targeting your sebaceous glands and destroying them. And we're going to be looking at other studies too. So let's look at another study that actually looks at the differences in sebaceous glands between people with androgenetic alopecia and people without. So when we look at the study titled, quote, Changes in the Sebaceous Gland in Patients with Male Pattern Hair Loss, Androgenetic Alopecia, unquote, by Katsuhiro Kuri et al., published in the Journal of Cosmetic Dermatology. Here, the authors explored the morphological changes in the sebaceous glands of patients suffering from androgenetic alopecia. The researchers examined 250 glass slide specimens from Japanese patients diagnosed with male androgenetic alopecia. They specifically analyzed 23 cases involving longitudinal sections of the scalp skin to determine the morphometric characteristics of sebaceous glands. One significant observation was the increase in the sebaceous gland area in patients with androgenetic alopecia compared to those without, although the size of each gland remained unchanged. So this suggests an overgrowth of the sebaceous glands in androgenetic alopecia affected individuals, which hints that the sebum output is much more amplified in these people. Additionally, the study utilized immunohistochemistry to identify follicular stem cells in the bulge region. Now, the presence of these cells in androgenetic alopecia patients indicates that while the follicular structure undergoes significant changes, the stem cells in the bulge region are usually preserved, right? There are cases where, especially over a longer period of time of androgenetic alopecia, we know this from the Sinclair paper when we look at the importance of the erector pili muscle, right? Because it is proposed that the erector pili muscle connects to the stem cell bulge area, and the stem cell bulge area contains the stem cells that are needed to influence hair growth, right? So over time, as the hair follicle shrinks and it loses its connection to the erector pili muscle, at least this is the theory that is proposed by Sinclair and colleagues, that connection to the stem cell bulge area is severed, and that can cause permanent hair loss. But it seems in some hair follicles that never really happens, and the stem cells are still preserved to some extent. So, going back to this study, it's encouraging at least to see in biopsy that, okay, yeah, you do have changes to the follicle organ overall and the sebaceous glands within that organ, but usually the stem cell bulge region is relatively preserved. And so long as that region is relatively preserved and there's no sort of autoimmune condition that destroys that bulge, theoretically that hair follicle could be regenerated, right? Even if it's not growing any hair anymore. And this is exactly what therapies like PP405 from Palage Pharmaceuticals and even AMP303, AMP506, AMP601, all these, therapies that Amplifica is working on, this is what it's trying to influence. The proliferation of hair follicle stem cells and getting those stem cells to differentiate into hair. So androgenetic alopecia, if you have it, it can make your sebum, different, and it can make your sebaceous gland larger, and it can increase the volume of sebum you put out, but it doesn't necessarily mean that it's going to destroy the hair follicle stem cells. But again, like I always say, if you have an issue with your PPAR gamma receptor, and that receptor is important for metabolizing lipids, again, what do I always say? If you can't do that, if your body can't do that in that specific tissue, it's going to cause an autoimmune reaction where your immune system sends in your white blood cells, your lymphocytes infiltrate specific areas of the hair follicle, whether it's the sebaceous glands or, sadly enough, the hair follicle stem cell bulge. And if it does that and it destroys that, that leads to permanent hair loss and fibrosis, hence the term cicatricial or scarring alopecias, because the follicle fibroses and scar tissue fills in its area. Man, I have to remember to breathe when I'm, talking, because clearly I'm off script and right now I'm just speaking off the cuff because all this is just so interesting and it's everything I've been talking about for the past year just coming together in a most, lucid kind of way. But this paper is pretty cool because when looking at this, I thought that it would be interesting to see if there's any way to predict or monitor the severity of androgenetic alopecia by looking at correlations that might exist between the sebum level output. Maybe, and in my mind at least, the higher sebum output invites for more issues for other conditions to make the hair loss one experiences in androgenetic alopecia overall much worse, right? So what am I saying here? If you have androgenetic alopecia, it could be the case that you're predisposed to a host of other secondary and tertiary conditions that can make your hair loss worse. And, I would argue that, not everyone has other, secondary conditions. There are people out here that are walking around that are just primarily dealing with one issue, and that's androgenetic alopecia. But I would argue that people are usually dealing with more than one issue. It could be a base diagnosis of androgenetic alopecia, right? And maybe with seborrheic dermatitis influenced by Malasthesia restricta or other Malasthesia type of species. Or maybe folliculitis caused by Staphylococcus bacterium or Cutibacterium that is really causing a acne or your sebaceous glands to swell up because the lipid content has changed to favor more triglycerides and decrease in free fatty acids and squalene, which causes those specific negative or harmful bacteria that are in very intricate and important places like the sebaceous glands to cause them to inflame, and then you get all these diseases, right? So this is something to consider because there are people out here that are walking around saying, why is my hair loss getting worse? I've been using dutasteride, and, dutasteride, it's decreasing DHT in the scalp and in the skin by a considerable amount based on what dose you take it at, right? But at the same time, you're probably, there's been a huge or profound change to your sebaceous glands to the point where you might have to do additional things, right, to kind of treat your, let's say, SebDerm, right? So we have to keep that in mind. A lot of people are walking around here not just with androgenetic alopecia. They have secondary and tertiary conditions on top of that as well. And they tend to be inflammatory in nature, which harm the improvement of their hair overall. Okay, I was talking a lot there, but I went on a rant. But again, let's return to what I just said. Is there any kind of, study that shows us that there's a correlation between this sebum level output and maybe the severity of androgenetic alopecia? Well, in 2023, there was a study titled, quote, Correlations between sebum level output and severity of male androgenetic alopecia, unquote, by Tannenbaum et al., published to the Bali Medical Journal. And it examines the relationship between sebum production and the severity of androgenetic alopecia in men, using something called a sebumeter. And this is a device, by the way, the first time I've heard of it, but it's a device that's used to measure sebum levels on the skin, scalp, and the hair. And just as a side note, I wonder if this device could be used to test DHT concentrations in the sebum. Maybe we should be using this, right? I don't know. It would be interesting to see, though, right? If you're actually changing the DHT concentration, if you're taking dutasteride in the sebum itself. But anyway, the researchers measured sebum levels across various scalp areas of 50 male participants to establish a sort of direct link between sebum output and hair loss severity as classified by the Norwood-Hamilton scale. And the study's findings show us a significant positive correlation, R equals 0.94, so that's pretty high, between increased sebum levels and the severity of androgenetic alopecia, suggesting that higher sebum production may contribute to the progression of hair loss. Now, again, DHT, we must remember, causes the sebaceous glands in genetically predisposed individuals to produce an excessive amount of sebum. But I have something to say, right? I wonder if maybe in clinical trials for androgenetic alopecia, which involve the use of topical therapies, if the reason why, maybe in some cases, why the placebo group improves in hair count simply has to do with the act of rubbing alcohol on their heads, which could kill some yeast overgrowth and, some negative, bacteriums. And it may inadvertently improve hair counts, right? This is some food for thought. Perhaps we need better methods where we monitor microbial life and sebum changes in all arms of a clinical trial, especially for the use of topical interventions for alopecia. Now, in this video, of course, I'm going to talk about PPAR gamma receptors again. It's been my obsession for the past couple of weeks, right? This guy never shuts up about PPAR gamma receptors. And why? Well, we know from conditions like lichen planopilaris or LPP, it tends to relate to a factor of lipotoxicity, right? Where when the PPAR gamma receptor is dysfunctional, in some predisposed individuals, whether they're predisposed in the genetic sense or environmentally, this could have an impact where you're having this horrible condition destroy the hair follicle stem cells, right? This is a really bad type of hair loss. And there's many variations in lichen planopilaris. You have frontal fibrosing alopecia, you have fibrosing alopecia in a distributed pattern or an undistributed pattern, and you have central centrifugal cicatricial alopecia, also known as CCCA. And then there are some other ones that I don't really, feel the need to get into the nitty-gritty of, right? But they tend to be variations of LPP, where histologically speaking, when you do a biopsy, they have similar features, right? And those features tend to be a lack of sebaceous glands or alteration of sebaceous glands. That's the first sign of a scarring alopecia. But I want you guys to think about this real quick. If you're losing your sebaceous glands or you're having your sebaceous glands partially destroyed, what does that mean for your microbiome on your skin, right? It probably means you have a lower presence of specific bacterium, especially yeast, right? Those Malasthesia colonies are not going to be as abundant anymore. And we have to remember, Malasthesia is a normal part of the human microbiome. It's, the only issue is when it becomes an overgrowth. That's when it can cause skin pathologies. But if you don't have them, or at all, or you have a very odd, lack of these yeast, maybe that indicates to a dysfunction of your sebaceous glands. Okay, so the issue was that we had too much lipotoxicity because the sebaceous glands were, pumping out too much, lipids, and your PPAR gamma couldn't handle it, and your lymphocytes came in and destroyed those sebaceous glands. But now you're saying, KWRX, well, a lack of sebaceous glands and lipids is a bad thing. Of course it's a bad thing, right? You need sebum to nourish your skin and to nourish your hair as well. Right? It's important. And you do need, some activity of microbial life to outcompete the harmful microbes on your skin. You live in the world. You interact with things that are dirty all the time. These, microbial lives that you have on your skin, it tends to give you a sort of symbiotic relationship where you give it a home, right? And it tries to kill things that are pathogenic to you. And sometimes you have a bit of a beef. You have issues with your roommates sometimes, or your spouse or significant other, right? And the Malasthesia in this case can sometimes become an issue where it leads to overgrowth, but it's still an important part of the human microbiome. So, I say all that to say, maybe a decrease in yeast colonies can be a bad thing, and it might point at an issue with your sebaceous glands. And in fact, Kimberly Williams et al., in a letter to an editor, said this, and the letter is titled, quote, "Histologic absence of yeast as a clue for classic lichen planopilaris, fibrosing alopecia in a pattern distribution, and frontal fibrosing alopecia, a cross-sectional observational study," unquote. And here it was found that changes in sebaceous gland activity typically reflected a decrease in human yeast species. Now, again, Malasthesia is an important part of the human microbiome on the skin. So, you noticing there being little to no Malasthesia or any sort of microbial activity on a part of skin, right? Maybe it's very, very low, it's oddly low, could indicate that, hey, there is a active destruction of sebaceous glands that's leading to a drying effect. And referring to a paper titled, quote, Lichen planipilaris in the Androgenetic Alopecia area, a pitfall for hair transplantation, unquote, we can see in biopsy how Lichen planipilaris and its variants show lymphocytic infiltrate, and this is where, again, the white blood cells surround and attack hair follicle structures, and we can make a special note on the destruction, whether in whole or partial, of the sebaceous glands in these biopsies. So, overgrowth of sebaceous glands could play an integral role in the pathology of androgenetic alopecia, possibly due to increased production of sebum that has poor quality. And this overproduction might contribute to the miniaturization of hair follicles, not just on one front where DHT is destroying the follicles, but rather you're having other sort of agitating factors that cause hair loss via inflammation, or rather excessive hair shedding or effluvium due to inflammation. The relative preservation of stem cells in the bulge region in most androgenetic alopecia biopsies, even in the midst of morphological changes to sebaceous glands, suggests that potential therapy interventions could manipulate these cells to regenerate and repair hair follicles. That's what Pelage Pharmaceutical is doing. That's what Amplifica is doing. And personally, I see those two companies as the lead globally right now when it comes to trying to get those hair follicle stem cells to essentially make new hair. But the overall takeaway is DHT is just such a horrible hormone in this case. It sucks. It just leads to a cascade of other issues that, if you're predisposed to it genetically, it can just make your AGA worse. It can cause you to have other conditions on top of it. And, this is why some people complain about dutasteride not being effective for them. If it's not effective for you, you just so happen to be one of those people that have another issue, right? And if you're not getting the hair growth you want, maybe you can look into what else you're possibly dealing with. Now, this is where using shampoos as a weekly maintenance helps, as you can make sure these yeast and microbial colonies are kept in check by using them for maybe 2 to 3 times a week. And personally, I've used cycloperox shampoo at 1% and have since turned my back on ketoconazole 2% because, one, I find ketoconazole, no matter what brand, to be too drying, whether I use the over-the-counter Nizoral 1% brand or I get that medicated 2% from, I think it's called Tiva or whatever, the Israeli company, whether I use that one, it's still drying, right? For two, right, the second point here, cycloperox 1% doesn't seem to dry my hair out, right? And when I use it, it gets rid of my SebDerm, right? I notice a difference. When I use the ketoconazole, it tended to not work for me, right? I still had dandruff issues, but with cycloperox shampoo 1%, by the way, it's not over the counter in the United States. You do have to get a prescription for it. When I used the cycloperox shampoo 1%, it worked for me, right? But there are some studies that show that cycloperox shampoo 1% and ketoconazole 2%, they might have similar efficacies, or cycloperox might kind of beat it out a bit. So in a clinical study led by Ravi C. et al., titled, quote, Clinical Efficacies of Shampoos Containing Cycloperox Olamine 1.5% and Ketoconazole 2% in the Treatment of Seborrheic Dermatitis, unquote, the efficacies of these shampoos were compared, right, in a randomized double-blind methodology over 4 weeks. And it also had a preceding 2-week run-in and a 2-week run-out period. So a total of 350 participants, with 150 in each group, the cycloperox and the ketoconazole group, and 50 in placebo, right? So we had 3 arms, 50 in placebo, 150 in both the cycloperox and ketoconazole groups. so 3 groups in general. And the study's primary efficacy variables included changes in the area affected by seborrheic dermatitis on the scalp, as well as the secondary variables such as the severity of scaling and itchiness. And both cycloperox and ketoconazole shampoo showed a significant effectiveness in reducing the affected area compared to the placebo, with cycloperox showing a slightly superior reduction. Additionally, patients' assessment rated the cycloperox shampoo higher than the ketoconazole and placebo in terms of overall improvement and symptom relief. So I guess cycloperox was better at relieving the itchiness, and maybe it didn't have as much of a drying effect on the scalp. The study concluded that cycloperox shampoo was not only superior to placebo, but was also at least effective, if not slightly better, than the ketoconazole shampoo in treating scalp seborrheic dermatitis. So it's studies like these that kind of made me incorporate cycloperox 2 times a week during my showering into my, I guess, hair loss stack or prevention stack. When it comes to my personal anti-inflammation stack, I use clobetasol propionate 0.05% solution along with calcipotriol 0.005% solution. And calcipotriol, by the way, is a topical vitamin D analog. And I use both of these two to help maintain a healthy sebaceous gland activity and also to reduce inflammation on my scalp. But I use them in a sort of maintenance kind of way, where I just use the clobetasol propionate alongside with the calcipotriol together, right, on the same day. I use it maybe 2 times a week or 3 times a week, right? I used to use it every day, but, sometimes, I don't use it every day, but at the very least, I try to use it at least 2 to 3 times a week. And the cool part about calcipotriol is that it has been proven to reduce the skin thinning effects that occur with long-term corticosteroid use, like clobetasol propionate. Calcipotriol is known to actually improve and make your sebaceous glands healthier as well. Calcipotriol has been used long-term for psoriasis. It's been safe, right? People use it even when their psoriasis isn't actively outbreaking. They use it as a sort of maintenance therapy. It's also been used for eczema as well. And the understanding for this is supported by the study titled, quote, calcipotriol counteracts betamethasone-induced decrease in extracellular matrix components related to skin atrophy, unquote, by Hain-Norsgaard et al., as well as the study titled, quote, long-term use of topical calcipotriol on chronic plaque psoriasis, unquote, by C.A. Ramsay et al. And there are other studies that I'll be putting in the description or the comment section for your convenience. Now, I do have folliculitis as well, as I noted in a biopsy from a year ago, so I incorporate in my shampoo routine, I use 10% benzoyl peroxide shampoo alongside with 1% cycloperox shampoo in the shower. The benzoyl peroxide is effective and can, you got to be careful because it can bleach clothing as well. So make sure you rinse out your scalp and remove, any sort of benzoyl peroxide you can see. Try your best doing this because I know some people like to use t-shirts to dry out their hair after a shower. I also use 1% topical clindamycin gel on a dry scalp once or twice a week. And this is to kind of keep the folliculitis at bay or just overall prevent it. I've also made some dietary and lifestyle changes as well. But I inform myself using the Merck Treatment Manual of Folliculitis, as well as the paper titled, quote, Scientific Rationale for Clinical Basis for Clindamycin Use in the Treatment of Dermatological Diseases, unquote, by Maria K. et al. And finally, I actually make use of one of Nizoral lesser-known medicated shampoos, and this is the Nizoral Psoriasis Shampoo and Conditioner. It's the green bottle, by the way. At the time of recording this video, it's like a green teal kind of bottle. But I use this as well. So what I do is, I get all of these shampoos, the benzoyl peroxide 10%, the cycloperox 1%, the Nizoral Psoriasis Shampoo and Conditioner, right? That one particular shampoo brand. And I mix them all together and I apply these shampoos maybe twice a week, 3 times a week at most to a wet scalp. You have to make sure your scalp and your hair is wet when you apply this because it won't actually work properly if you don't do that. And then I focus on, using my fingers to lather these shampoos into my scalp for about 5 minutes. And then I wash it out, I wash out my hair, and then I follow with a conditioner of my choice. So, yeah, that's pretty much it. And hopefully this video is helpful for you guys. And, typically people with recurrent folliculitis, I know some people have mentioned this as well. What do you do for recurrent folliculitis? Well, with recurrent folliculitis, you have to make some lifestyle changes. I did do an interview with someone that had folliculitis decalvans, actually, on my channel. I want you guys to go check it out. But he did some lifestyle changes and it helped his hair grow back. But it tends to be that some people start with a course of doxycycline. This is a tetracycline. It's an antibiotic, but they do 200 milligram either once or twice a day, and you have to eat it with food. If you don't eat it with food, it's going to destroy your stomach. Trust me, I know. But they do this at once or twice a day for 1 month up to 3 months at the very most, if it's severe, all while using the shampoos that I mentioned, the benzoyl peroxide and the cycloperox, right? And the shampoos are typically used as maintenance afterwards as well. And just because you don't actively have an outbreak doesn't mean you stop using it. Just hope some people know, right? And there's also apremilast that has also been noted to help people recover their hair and scalp from folliculitis and folliculitis decalvans. And we can see this in the case report titled, quote, "Successful treatment of refractory folliculitis decalvans with apremilast," unquote, by Mirjam Fassler et al. And the treatment used oral apremilast, not topical. The patient took oral apremilast, a PDE4 inhibitor, as a monotherapy without any additional systemic or topical medications other than 2% chlorhexidine shampoo, which was used at the patient's discretion. The marker that helped the patient in this study was the rapid suppression of neutrophilic inflammation, as evidenced by the resolution of the itchiness, the follicular pustules, the crusting, and the hair tufting on the scalp. The treatment led to a nearly complete remission of folliculitis decalvans within 3 weeks, which was confirmed by trioscopy, showing the complete removal of follicular hyperkeratosis and perifollicular erythema. We also see some cool biopsies over here as well, so that's pretty nice. So for those of you, there's one guy in my audience who keeps asking what to do with recurrent folliculitis. What I just explained, right, is something that could possibly be employed, so go talk to your doctor. And remember, just because you do it once, right, it's likely that you will have this issue in the background in your scalp, so you have to make some lifestyle changes. I guess try to consume more omega-3s, right? But also using these shampoos twice or 3 times a week should help keep things at bay. Also, maybe consider asking your doctor about a topical apremilast shampoo or a topical doxycycline solution. That could also help as well. So just be smart, know what to incorporate, talk to a doctor, and yeah, that should help. Anyway, I've rambled a lot in this video. Hopefully this tackles a lot of this, sort of scalp microbiome issues that some people have in my audience, and hopefully I was able to articulate myself when it came to the issues with the lipid production. I'm not going to be talking about diet. Diet is a crazy debate, and a lot of people from certain channels don't seem to understand that some people genetically can't consume certain things, right? And we shouldn't, just be sitting here making there is a good diet conceivably out there that we can all eat and, live well on, right? But a lot of the diet discussion that I'm seeing on YouTube lately, again, from specific channels, it's very dogmatic and it's very conspiratorial too, right? Where people ignore a lot of things from studies, right? And also when I think about, the PPAR gamma dysregulation, look, you can eat a vegan diet and you'll still have that issue. You can eat a carnivore diet and you'll still have that damn issue, right? Some people just have genetic predispositions and there's not much they can do about it other than taking medicine. So that's it. I don't want to comment anymore on diet. There's a reason why I didn't bring it up in this video. But yeah, hopefully that helps you guys. This video helped you guys, and I'll see you in the next one. Peace out. Because I've talked so damn much in this video. Pray for the editor. Give him a shout out, guys. Nail. Sorry for rambling too much, but yeah, I got you though. Anyway, see you guys. Peace.